So I'm happy to be here to do the author interviews for GIE. I'm very pleased in particular to be able to interview Jennifer Higa, who's a bright young endoscopist currently in Philadelphia, but was from my home region in the Northwest, did her fellowship with Dick Kozarek and Cheyenne Irani. And she's here to discuss, or we're here to discuss together, her work on LAMS, lumen-apposing metal stents used for draining gallbladders. So why don't you tell me how you picked that subject to get involved with for this presentation
Sure.
and this paper?
Thank you for having me. We are specifically looking at our outcomes at the center in Seattle, comparing ultrasound-guided gallbladder drainage with transpapillary gallbladder drainage, which had not previously been published for any US-based series. There were a number of recent publications looking at ultrasound-guided transmural gallbladder drainage, including prospective and multi-center studies, but to date we don't have too much evidence to compare both endoscopic methods of drainage. So that was the impetus for the study.
Yeah, for me it's a very important paper because I think I'm fairly sure you guys have the largest series in the United States of LAMS gallbladder drainage. I think the total number was how many in your paper?
We did 40 over a 5-year period, and there are multiple centers currently doing transmural drainage, and I think it's definitely become more of a foundational way to manage these patients, these high-risk non-operative candidates who present with acute cholecystitis. And I don't know that we have the largest series, but I think certainly comparable in the literature, since it's relatively novel. And especially with the advent of the cautery-enhanced LAMS, there's been much more enthusiasm for this form of drainage.
I should mention that currently the use for gallbladder drainage is off protocol. I mean, it's approved for use for pancreatic pseudocyst drainage.
Correct.
Were these all done under an IRB?
Yes, we had obtained an IRB for this study.
So that's good. And maybe you can just summarize your conclusions comparing the transpapillary drainage?
Sure. So these patients all presented, they were non-operative candidates, presented with acute cholecystitis. And there were 78 total patients. 40 of them underwent initial attempt at ultrasound-guided drainage and 38 for transpapillary. Some of these patients had previously had an ERCP and biliary sphincterotomy, and the ones who had not underwent biliary sphincterotomy and then transpapillary cystic duct stent placement. In general, we looked at technical success rates, clinical success rates, adverse event, recurrent cholecystitis, et cetera. Demographics were generally similar between the two groups. There were more acalculous cholecystitis patients in the ultrasound-guided group, but overall pretty similar. And in the univariate analysis, we were able to detect somewhat of a difference between the technical success rates and the recurrent cholecystitis rates favoring ultrasound, but this difference was lost on multivariate analysis, I think likely reflecting the number of patients. Clinical success, though, was markedly different between the two and favoring ultrasound-guided drainage. And that's been consistent in the literature, that patients who undergo ultrasound-guided drainage seem to resolve quickly and well. And especially when they compare ultrasound-guided drainage to percutaneous transhepatic catheter placement, patients seem to do quite well under ultrasound guidance.
Yeah, of course, the percutaneous approach is quick and relatively easy, but it has a lot of tube-related problems and issues like that. So.
Yeah, and there's a great sort of foundational base for use for percutaneous drainage, but I think that if there's evolving evidence to suggest that we have safe and efficacious endoscopic methods for taking care of these patients who many of them prefer to have internal methods for drainage.
Right. Now, Virginia Mason's a rather peculiar place because it's such a high level, even beyond tertiary biliary endoscopy center. And do you think out in the general community transpapillary drainage would actually be a little bit more difficult for many, kind of in some of these complex situations?
Yeah, I think even in experienced hands, sometimes you run into anatomy that's just not favorable, and you don't know that until you're in the situation. The cases that had failed transpapillary drainage in our series were patients who had indwelling biliary stents that uncovered metal biliary stents that obstructed the cystic duct takeoff or had obstructing stone disease. So in those cases, we would favor probably upfront considering ultrasound-guided drainage for endoscopists who are comfortable, have enough experience, and the literature on learning curves and doing these interventional EUS procedures would support that in experienced hands, these procedures are relatively safe.
So you've had a very thorough education in both the EUS and biliary endoscopy. In your current practice in Philadelphia, is your preferential approach based on the results of the study going to be EUS-based, or is it going to be ERCP-based?
You know, I think that, so when I've seen these patients, we always see them in clinic first to discuss that there are different ways to manage this and that there are certain patient characteristics that should be accounted for. Obviously, presence of metal stenting. If there is a large volume of cholelithiasis, then those patients seem to do better with ultrasound-guided drainage to directly address the stone burden through cholecystoscopy. And that has a well-established role. Primarily in China, there have been a number of series that have come out suggesting that it's got a great role to deal with that. And I think that it's nice to upfront discuss with the patient what you're thinking and absolutely getting surgery involved and making sure that they talk with a surgeon to verify that they don't have plans for surgery. If they do think that they might eventually go for a cholecystectomy and this is a temporizing measure, then we typically try to prefer to maintain the normal anatomy. Although we did have some patients out of our series end up going for cholecystectomy. We pulled the lambs and then they did an enteral repair.
Yeah, it makes it quite a bit more complex. So thank you from the surgery standpoint. Now, these were very sick patients, obviously, and there are some complications in your series. Can you just briefly give a summary of those? And
Sure, yeah. So in the ultrasound, the EUS arm, the predominant complications were related to either bleeding that were investigated endoscopically but didn't require treatment, and stent migration. And those stent migrations were managed by retrieving the stent, one of them unfortunately with a double balloon. And there was one patient who was quite ill and had some extraneous circumstances, had refused a percutaneous drain, and there was evidence to suggest that there might be perforation of the gallbladder, and that we had a very extensive discussion with the patient ahead of time that this was a potentially quite morbid way to manage. The patient didn't do well and ultimately succumbed from complications of sepsis. And the transpapillary arm, there were some issues with pain. There was one patient who had pain and required admission, and one patient who had issues with cystic duct perforation. The gallbladder neck had actually necrosed. The patient was quite ill. And ultimately that patient went for ultrasound-guided drainage. So I think, you know, these patients are non-operative candidates for a reason, and they're quite ill, and so having a really in-depth discussion with the surgery service and, you know, making sure that the patients have a very clear understanding of what the risks and benefits are is paramount.
The two patients that had bleeding, I believe, in your series, were those happen to be patients on anticoagulation, and maybe you can describe how you deal with that for either the transpapillary or the EUS treatment? Sure,
I think there's always this risk-benefit sort of decision that you have to have with yourself and the patient, and we stopped systemic anticoagulation for the procedure, but start it shortly thereafter, especially if the comorbidities favor restarting systemic. You know, the patients who did have bleeding were on systemic anticoagulation, and when we investigated the bleeding, it was likely related to the stent but didn't require intervention and stopped on its own. So I think it's something to keep in mind. We do place double pigtail stents to minimize risk of transmural wall, contralateral wall injury from the other side of the lambs. So something to consider.
Well, again, thank you. It was a pleasure to read your paper, and nice to meet you, and thanks so much for bringing that work to us.
Thank you.
Mm.